So, hey, Carolyn. So far, no one else has come, but we might as well get started. If others join us, that's going to be lovely. So today, I just really wanted to talk about suicidality and kind of the gray zone. A lot of times patients come in and they're suicidal and people wonder, hey, why didn't this person get admitted? Or this person attempted suicide, why didn't they get admitted? And I just wanted to talk about what that gray zone sort of looks like, where sometimes we feel the patient's not going to have a therapeutic environment when they're coming inside the patient's to the inpatient setting, or if we feel that they're not high enough acuity to be inpatient. So a little bit of conflicts of interest. I have none, sadly. No one else pays me. Some of the objectives about today is to specify suicide risk factors, analyze how risk factors play into safety planning, and apply strategies for incorporating risk stratification and safety planning in clinical practice. All that to say is we're going to learn about the risk factors and see how they come into play when we're admitting someone or when we don't. So, oh, sweet. Thanks, Carolyn, for showing your camera. Maybe you shouldn't have done that because I would love for you to read the first case study if you can for us. Is your mic
So
working?
you and I will have the conversation about suicide. So great. That's okay. I'm listening.
All right. Could you read the first slide for us?
Oh, me?
Yeah.
Okay. A nurse practitioner is a middle-aged female with a long-standing history of depression, is at the emergency department after an attempted OD with a few benzos and muscle relaxants. She had saved after her knee surgery and drank a fifth of vodka impulsively. She had been a divorcee for a year ago and was fired from a previous job. She hasn't been taking her meds. She just moved to New Mexico from the East Coast a few months ago and only had 3 friends here. She's having housing instability due to a strange landlord and spent her money making a practice. What should you do?
Thank you so much for reading that for us. So what should we do? Well, first, let's actually go through some of the risk factors, right? Of course, psychiatric illness is a risk factor for suicide. Race is a factor for suicide. Marital status. Her being divorced is a higher risk. Is she living alone? Is there recent personal loss, unemployment? And this laundry list that I've put up here is just for us to review what the risk factors look like, right? A lot of patients will come in saying, I'm having financial legal difficulties. I have a gun at home. I keep it unlocked. I have bullets. So these are all things we start looking at when they actually say they're suicidal. And we try to create what's called a risk profile. And one thing is based on our interview and some of the modifiable risk factors. We look at how we can manage their illness. We look at what their individual risk profile looks like and what their circle of support looks like. So all of these things are part of how we're going to decide whether we admit her voluntarily or involuntarily.
I have a question before you go on to your next slide. Can you share this with me or whoever is on the call as a way to sort of really use this tool to assess suicidal patients? Is that something you could do?
Of course, and we can send this slide set out to everybody who's registered.
Okay.
We'll make sure.
Awesome.
Thanks so much. Yeah, of course. So do we admit her at all? Really, it becomes the question. So we separate this into our reasons for yes and our reasons for no, right? A lot of times somebody comes in with a suicide attempt and we say, all right, that's automatic admission. You're getting admitted. That's not always the case, especially here in New Mexico, where we're really limited by a lot of our resources. A lot of times we spend a lot of days waiting for transport when we have no beds in Albuquerque to transfer patients to Mesilla Valley or the Peak or another facility. And same thing happens with patients that are waiting for admission. Our idea is that we need to get them through a crisis time, but they may not require admission because after a few days, they would have been discharged anyway. And the number of days that they spend waiting in our emergency departments can actually be getting them through the crisis itself. looking at this specific case, right, we think, oh, there was an impulsivity, there was intense emotion, there was poor reasoning, recent job loss. But the patient is a health practitioner. They can see a private psychiatrist quickly, can make a follow-up appointment within 2 days. They can take their medications, and we were able to get their friend, another nurse, who was their significant other, to watch them for 3 weeks while they were at home. They were going to drive them to work, and they were going to pick them up. So they were going to have someone with them 24/7. And we got them to throw away all the medications in the stash, and there were no guns in the house. So what would you personally decide, right? We look at some of these important risk factors here, and she has so many of them. Does anyone want to pipe out what they think they should do?
I can't really hear you. Can you turn up your volume?
Sure, if that's the case, let me see what I can do.
I turned mine up all the way, but I'm like straining my ears. Sorry.
Everyone hear me?
Yeah, I can hear you.
I'm having trouble hearing you guys now. No worries, as long as everyone can hear me.
Yeah, you sound good. You sound good on our end.
Oh, perfect, perfect. I was just worried I couldn't. Oh, I can hear you guys well. Perfect. So let me go back to my screen. So what did you guys decide after having some time to think about it?
Ask the question again because I didn't hear you.
Would you admit this patient?
Oh, admit this patient. Well, no, I would say no.
Exactly. That's right. We did not actually admit this patient. And our reasoning was that she wasn't taking her meds. We can get her to start taking her meds. We can get her a follow-up within 2 days. And her time for crisis had passed. She had been in the emergency department for a couple of days. She had cleared the alcohol, and she had been drinking in the context. So we thought this was less risk. That's not to say that she's not no risk, right? A couple of statistics for people to remember that someone who commits suicide, has a completed suicide, oftentimes it takes 8 attempts to get them there. However, a lot of times when someone tries to commit suicide, only 5 to 11% of those patients will actually have a completed suicide. So the numbers suggested that we could probably be safe to let her go, especially given the fact that she had money, her boyfriend was able to come with her, was able to take some time off work, and was able to start taking some day shift jobs instead of night shift so that he could be with her. And we felt that was a pretty strong case to be made, that this would be a good environment. So we discharged the patient home. All right, we have somebody new with us. Perfect, Amanda. So now we have a second case. Would you mind reading this one for us, Amanda?
Sure. So you're a member of the Albuquerque Crisis Intervention Unit. You encounter a patient who is manic, setting a fire to everything and anything. They have already surrendered 2 guns to APD, but you suspect she has more. What do you do?
Okay, so let's take a minute. You have a person, let's say mid 40s, 50s, meeting all the regular dig fast symptoms that we think about when we think of bipolar mania. They're distractible, impulsive, they're not sleeping, they're very talkative, they have flight of ideas, they're very tangential, intrusive, setting fire to everything that you can see. This is their front of the house. They think people are out to get them. They've barricaded it. What do you do? And they've surrendered 2 guns earlier, a couple days ago to APD, but you suspect they have more.
So a lot of times with cases like this, you think it's a little bit more clear cut, which it is. Remember, patients with bipolar disorder are 10 to 30 times more likely to kill themselves. 20% of bipolar patients die by suicide, often when they're untreated and in their manic phase, because that's when they're impulsive more. 20 to 60% attempt suicide at least once. And I know that range is really high, but people in mania are really at crisis, and we need to take it very seriously, right? That people are in crisis, they need help. So that's what we encourage our patients who are bipolar, who are having mania, to come into the hospital. Sometimes you might hear the word, say, pleasantly psychotic. People with psychosis are not very much likely to always hurt themselves or others. It's something like 2% of them will. So when you interview the patient, you can get a clearer idea, but a lot of those patients may not need inpatient hospitalization. Bipolar patients more often do. And this is some things that we start looking at, right? When we would say they have protective factors now, we would look at what are their academic achievements? Are they aware of what local access they have, right? This patient was connected with a crisis intervention team. Are they connected with their parents? Is there safety in their neighborhood? What is their level of resilience? Are they close to any friends or caregivers? Or how much safety is in the school? And that's what we start looking at. And yes, that was a little bit more clear cut, but the reason I bring this one up is that I want to remind people that different psychiatric disorders have different rates of suicide. And this is pulled from one of the papers. The documentation didn't show up, but the first line here is called a standardized mortality rate. And this is the ratio of the number of deaths observed in a population over a given period to the number that would be expected for the same period if the study population had like age specifics as the standard population. And we can see that people with certain disorders actually are increased. And in this study, we do see psychotic disorder as being even higher than bipolar. And of course, this should be taken as a case-by-case basis to see what's happening with the psychosis and if psychosis is involved with substance use disorder. And that's sometimes very difficult to tease out if it's an organic psychotic disorder or something that's coming from substances. And that's the only reason I have this slide up here, is just for us to remember it. Now, since you guys have talked a lot about the cases, I'll read this one for us. So this is a 46-year-old male combat vet with PTSD, tries to shoot himself, but his .43 Glock jams. He then drives himself down from the mountain that he had gone to and self-presented to the VA. He recently was fired from his job due to allegations of sexual harassment. He does receive VA benefits, but he hasn't spent any of it because he's guilty that a lot of his members in his cohort have died from his unit. Now, he's getting admitted, but what's the problem here? I just want you guys to take a second to think about this case. What's the issue with everything going on with him? A few things to also consider, just for you guys' knowledge, is the threshold for admitting patients at the Veterans Affairs Hospital is lower because they have more resources, and a lot of times we can get them a bed at the VA. And we also want to really keep our veterans safe. And we recognize that the veterans themselves are a more high-risk population than our general population, which is why we're also a little bit more careful to admit our patients rather quickly for them. Okay, so we'll talk about him, but just keep him in the back of your mind as we explore the case fatality by suicide method. One issue that a lot of times will come up is firearms, right? Firearms have a high level of fatality. These are other methods that also have high fatality rates, but you see that everything decreases, and the highest one in the United States is firearms. And it continues to be in the United States, where we have quite a bit of access to weapons. Mind you, this is not a political viewpoint. This is simply saying I would like you guys to remember that guns can be very serious because they have high lethality. Means matter. We need to understand the lethality of the method that our patients have. What is the inherent deadliness? What is the ease of use? What is the accessibility? What is the ability to abort mid-attempt? And is it acceptable to the attempter to have this means? One other way that you can actually see if the means are very lethal is using the Beck Suicidal Intent Scale. That's not something I included here. You can look it up on up to date if you really wanted to use that. as part of your risk stratification tool or part of your documentation. But realistically, what is the problem is with guns is that they're very deadly. They're very easy to use. They're very accessible for majority of the population, especially for our veterans. And there is no ability to abort mid-attempt. In this case, his gun jammed, but that's not always the case with weapons, right? And that's just something to keep in mind is the higher the means and the more lethal the means, the more concern we should have for our patient when we decide to admit them to the hospital. And we want to understand that part of risk stratification for us is to reduce have a means reduction. So different methods have a different intent level. If someone's impulsive and combines some Flexeril, a muscle relaxant, with alcohol, it's very different than our patient here who pointed a gun at his head and shot himself or attempted to shoot himself. People often prefer what is easiest or simply available. One example that I will give is that in the 1990s in Sri Lanka, there was a drought. And a lot of farmers had access to very lethal pesticides. And their accessibility was one of the main ways that they were killing themselves. So in response, the government restricted these lethal pesticides that the farmers could not get hands on, and it went down in terms of suicide rate. That's very important for us to understand. Now, guns aren't the most common way to actually commit suicide, but they're the most fatal, right? We just talked about the means, right? The lethality is very high for weapons. And America owns a lot of guns. So this is why we want to make sure that we're being culturally sensitive to our patients that own a lot of weapons. We want to understand that for many of them, especially our vets, that guns, like a Mandalorian, are part of their religion almost. Or perhaps they're from rural areas where weapons are a way of life to make sure the foxes aren't hunting any of your cattle, to make sure the scorpions and the snakes are shot. And that's why we want to keep that in mind. But we also have to remember suicide risk increases with firearms in the house by at least 5 times, and more so if they are unlocked. And this is dangerous because even in the next year, in cases of hospitalization, aftercare follow-up, there are pretty serious follow-up attempts as well. Remember how I said at the very beginning, suicide can be a protective factor in the sense that 5 to 11% of people who try to commit suicide once will actually eventually commit a completed suicide. But that means 90 to 95% of patients. Oh, sorry, Carolyn, you're not muted there. Let me mute you real quick. Sorry, I lost my train of thought. So we want to make sure that the guns are locked up. And harm reduction for our veterans and others who carry guns is to store the lethal means in a secure manner. Every step that we remove, right? If we lock up their pistol, then they have to unlock the pistol first of all. Or if it's in a small safe, they have to get this, unlock it, and then take the gun out. Or if it's in here, they have to take their gun out, load the gun, then make an attempt. We're removing the level of impulsivity that the patients will have. And this is why the harms reductions matters. And there's a lot of good evidence that the VA has done that really support what we're saying here is to lock them away. So going back to the case that we had, the reason that I want to bring this up is that some patients are lying. I know that our job is to give the patient the benefit of doubt, but a lot of times when you fire a Glock and you fire 500,000 rounds and you don't have a single misfire, you start to wonder if the patient was lying to you. And that may be the case. Remember that he had sexual allegations, harassments against him at work. And that can be traumatic, and that can be a reason people are wanting to commit suicide. And we want them to get through the time so that we can help them get through the crisis. The high lethality, high impulse manner can be a recipe for disaster. And that's what we want to emphasize here is that's why we kind of harp on weapons, guns, knives, sharps in the house, razor blades, is because these can be very monumental. Very quick judgment can last a very long time, if not forever. And one thing that I always emphasize with our patients is as long as there is breath, there is hope. And little by little, or poco a poco, we can change that. So we're trying to help them. Oh, that's a lot of my voice. Juanita, thank you so much for jumping on. Would you mind reading this slide for us?
A 17-year-old male comes in on the behest of his adoptive mother for his depression. 1 week ago, he was seen in the emergency department for a GSW to his femur and was surgically treated by orthopedics. When spoken to, he admits frankly that no one asked him if he was suicidal. He had been drinking and smoking weed and was really sad about his girlfriend breaking up with him. Why does he get admitted?
Perfect. Thank you so much for reading that, Juanita, for us. Sorry, perfect. You muted yourself. So we looked at this case and we wanted to know, should we admit this kid? It had been some time since he had already taken the shot. It had been some time since he had gotten the surgery and undergone the open reduction internal fixation from the orthopedic team. And we knew that his girlfriend had broken up with him previously, and he was currently no longer drinking. He was currently no longer smoking, and that gunshot had taken place in a different friend's house where the gun had been unlocked. At his home, there were no guns, and his adoptive mother was keeping a very sharp eye on him because she was very scared. And her inclination that this was a suicide attempt was spot on. This is what we started doing, right? This is what we do is called a prevention-oriented risk formulation. And what we do is we look at the clinical data. Here we saw that they had recent suicide behaviors. We saw that they had ideation still, and they had depressive symptoms that were major enough to be labeled MDD. They had stressors. They were currently feeling very lonely. They had no access to their biological parents, who had only recently given them up for adoption. They were suffering still, feeling really stressed out that they were about to go to the senior year of high school, but the whole summer they felt like they were going to be alone from their friends. They weren't really engaged in outpatient therapy. They weren't engaged with a psychiatrist, and they had only seen their pediatrician twice in the last couple years. One time for some vaccinations, and then the other time for a follow-up visit after the gunshot. And the interesting thing for us was that no one had asked if he had been suicidal or if this was a suicide attempt, which was another thing that made us pretty scared. We knew that as his 17-year-old, he was very impulsive. Now, I know how I was as a 17-year-old, and pretty impulsive myself, but there was a level of lack of some control for them. Now, he continued to have substance use as a 17-year-old. He was drinking and smoking marijuana. And remember, alcohol makes us disinhibited. So we knew that this was going to be a problem. Very high risk status, pretty high risk state. Available resources were very little. But we luckily had a discharge recently on that day from the CBH, and we were able to admit him to unit. So we figured we'd be able to get him plugged into our support structure, get him a social worker, and be able to treat him and get him medications in hand if he needed to be. And these foreseeable changes we could only do in the inpatient setting for him. We couldn't get him a social worker outpatient. We didn't know how much follow-up he could really have. So our plan was to admit him. Family agreed, and he agreed that he needed it. And that's why we admitted him, right? Let's go to one of our final cases. And since you guys have all read, I'll volunteer to read this one myself. We have a 15-year-old female to male boy presenting to our PES with suicidal ideation with a plan to slit his wrists or take a bunch of bars because he can't see his girlfriend. He feels like his dad won't accept him, feels withdrawn, and feels like there is no hope if he was allowed to leave. Keep that in your mind. We spoke to mom and dad. Dad was waiting outside in the heat because every patient at the time was only allowed one visitor, COVID restrictions. And dad didn't want to leave too far away, even to go to his truck. So we started thinking about this. And we recognized that, first of all, he was conditional. He had future orientation. And we wanted to recognize that trans youth especially female to male, have the highest rate of attempted suicide. And specifically within the subset, 50.8% are for those who are female to male. There are many disparities. I'm sorry, I've spoken way too much today. There are many disparities that impact the trauma on people of color, especially in the LGBTQ youth. And we really wanted to respect that and say, okay, we recognize where he's coming from. But we actually let this patient go home. And the reason for that is I want to come back to our clinical data and risk formulation strategy here. While they were having family discord, the father was very much on board that he wanted to do the right thing for his son, whatever that looked like. Even though he didn't understand it, he was willing to come with the son, speak to me, speak to the other doctors, nurses, so that we could have the right impact. He was willing to give his son the medications that we prescribed. He was very uncomfortable with any sort of testosterone, but he was on board to give psychotropic medication for depression. And you know what? That's a starting factor. And mom was on board as well for that. And the patient had a good relationship with mom. Yes, there are a lot of long-term risk factors, but we started looking about what are the acute changes that we're having. The past suicidal behavior, the patient had never attempted suicide in the past. And while they were very impulsive 15-year-olds, we recognized that mom and dad locked everything up. Dad had already removed all the guns from the house as a safety precaution. They had already moved the knives away in the kitchen into a locked drawer. And they had removed the door from their kids' room, just as a safety mechanism, nothing else. And so we started seeing that while the kid was stressed, there was a lot of social support and family support that this kid had, even though they were very hesitant to accept their former daughter as their son. And regardless of your politics, one thing I want to point out here is just by using the correct pronoun, you decrease suicide rate by 50%. That is not anything more than gender affirming care. We're not saying testosterone. We're not talking about starting them on any sort of hormone. Simply using the correct pronoun that the patient identifies with reduces suicidality by 50%. There is no medication that reduces suicidality by 50% like that does. And that is very eye-opening. And once we shared that with the family too, they were very amenable that they're going to try their best and they were going to work on it. And that was a huge stepping stone for us. Like I said, a lot of these changes are little by little. And not everybody you see in psychiatry is going to be at this high level of risk. In fact, majority of our patients are not at this risk. It's simply the ones who come into the hospital requesting help or the psychiatric emergency rooms or services that are at this level. So that's why, based on everything we had and the resources we had within the trans community, the social worker that we had, the access to resources we had, were we able to say this patient's safe to go home because we think these protective factors outweigh the risks. So one thing that I also want to talk about is we had some other harm reduction techniques in this patient's case as well. We had a family member to help us manage the medication doses. Obviously, when you have a patient who's a little bit older, it might be a friend rather than a family member, or it might be a spouse. You can have them give the medication. And if they're on a PRN medication like hydroxyzine, you can teach them about the signs that they're having when they're having anxiety. You can say, are they having difficulty catching their breath? Do you see them get really anxious? Do you see them start sweating? Do you see them withdraw and go into a corner? All of these things we can use to say, hey, this person is now having anxiety. Why don't you give them hydroxyzine? Why don't you give them a propanol? And for very severe cases, okay, I think it's time that we try a little bit of an Ativan, right? You can ask the doctor or pharmacist to limit the number of refills or amount of medication prescribed. There's nothing stopping us from saying, hey, I'm going to give you a medication for a week, and then I'm going to give you some refills for that medication. And when you get the refill, I want you to give me a call so I know that you've gotten it. And so you're able to keep track that the patient's picking up the medication and then coming back. And you're able to work with them a little bit more. And I know that this requires more effort on our part, but also remember that inpatient setting is not for everyone. And we have limited resources. And part of our professional duty is to make sure our services are used to the best of our abilities and are utilized in the correct manner. And this helps us do that. And another easy way that we can also use is a daily pill box. We can set aside the pills for the week and we can lock the rest away with our family member or friend or spouse. So these are our other harm reduction techniques that I've talked about here. Just remember that everything is about harm reduction. And our biggest priority for our patients is their safety. Autonomy is the most important thing for American medicine. The only time where that isn't the case is when there's a safety concern and they are a clear or present danger to themselves or others. And these are the things that we can do to help protect them. Because at the end of the day, our patients are why we do this. And they are our most important, the most important person in the room. Some of the takeaways that we have, of course, there are many risk factors. You know, I gave you that laundry list at the beginning that I didn't want to read. Remember that some patients can be discharged if they make a strong case to go outpatient or get intensive outpatient treatment. Some patients that come into the emergency department, people will say, oh, they need to be inpatient. You'll hear a lot of the ED docs say, oh, this patient needs to be in the hospital. Let us make that decision, only because sometimes there's a little bit more nuance and our resources, like I said, are limited. So always remember that. And of course, some risk factors are much higher than others and risk should be stratified as such, right? We talked about what their background is. If they're a veteran who lives in Tijeras, New Mexico, and they have a bunch of guns and they're a combat vet, their risk factors are really high, right? It's very different than a 9-year-old who said they want to commit suicide after their mother took away their cell phone. It's very different risk stratification. And we want to recognize that. And we want to harm reduce as much as we can. And we want to make sure there are no lethal needs for anyone to have that has quick access to. So with that, guys, please, I encourage you to ask your questions. You know, of course, you'll have my email after this. We'll send the slides out to everybody who's on the presentation. Oh, perfect. I see something in the chat. Let me see. Oh, and there's a little survey there as well. If for the CME. Perfect.
I have a question.
Please.
Okay, my question is with adolescent females. I know that they don't have guns, but sometimes they have the hanging is the way that kids do, and then also by cutting. You don't necessarily see the cutting on their arms, or I've seen where they take their toenails out or cutting on their legs where nobody sees them. So I've had some of these kids sent to peds, and I wanted them to be hospitalized because they were not stable. And it's like you're saying, it's a gray area because the cutting may be mean something else. But when do you determine the gray area? When is it really we need to be concerned that this is something that they really want to do is take their own lives? Or is it something that they're cutting to feel that emotional pain release?
This is a very good question. So first of all, like with everything, it's very nuanced. It starts with your physical exam. My joke to all the other psychiatrists and our med students is often, all right, well, what does your physical exam show? And always take a nurse in there to do a physical exam. Because with cutting, the places that I want you guys to notice are the shoulders and the hips. I want to know how deep those wounds are. Do they need to be dressed? And I want you to know which direction they're cutting and have they hit any major arteries. Someone who wants to kill themselves will try to go after their femoral artery, their carotid artery. They'll want to slit their wrists vertically instead of horizontally, and they will not be superficial. They will be scarring and deep. And you will notice certain areas where they have really almost like levels that are raised. And you will see very marked skin changes. And you can see how old some of the wounds are. And that's part of your risk assessment is how long have they been doing this? How deep are those wounds getting? And what is their current level of suicidality? And you're right, the methods that we've noticed recently, the young females are complaining about wanting to hang themselves, suffocate themselves with bags. And that is a very different level than what we normally expect, is we expect a lot of them to want to use pills so they go quietly. So with those in mind, we'll try to admit somebody. One of the recent cases that we had that we admitted involuntarily was someone was mixing chemicals together. And they had Googled how to mix the chemicals. They had mixed them together in their car hoping to die. That was a high risk. And though they mid-aborted during the mid part, because they felt so guilty that they wanted to live for their parents, they stopped what they were doing, got out of the car, threw the chemicals away, and then drove back home with all the windows open and went and slept in their mother's bed for the night. They still needed to be admitted because it was a very serious thing. And if you ever have questions like that, I do believe you can call our PES and we can try to evaluate too. Especially you can have our attendings give a doc-to-doc or can give advice. If you call the PES, we can evaluate the patient. I know that we have a connection with like SRMC. So you're right, it's a nuanced question, it's difficult, and that's the gray zone is, okay, well, how deep were those cuts? How many places are they? And where does your physical exam show them? And that means a full physical exam. A lot of times, we're hesitant in psych where we don't always do a full physical exam. This is one of those cases you do need to, and you need to put them in a gown and you need to check everything, and then you can have them change back. And you can tell them that, hey, I know this might feel traumatic. I know this might feel really like a violation, but I just want to make sure you're staying safe. Because the biggest and most important thing for me is you stay safe. And you can even ask them, where else do you cut? What else have you done to hurt yourself? What else are you doing? What have you looked at? Have you looked at Instagram, Tumblr, wherever else? What websites have you used? And you'll start realizing the patients will give you a lot of information. They might say, I go on Pinterest to see how to starve myself. I go on Pinterest to see how to do X, Y, Z. And you'll start learning a lot of what they're doing just by asking them. So I hope I've answered your question, but good question. It's very nuanced. First thing is do a physical exam, go from there.
Thank you for answering my question. It's really hard when you work in a rural frontier area when the doctors do the assessment, but how I see it is when I have been working with this adolescent for a while, and then I see them walking really gingerly down the hall, and I was wondering what's going on with her leg, and I probed her and asked her, what's going on with your leg, and what have you seen the doctor? And come to find out, she had pulled a lot of her toenails out. So that was quite interesting. So just for your information, thank you.
Of course. And thank you for doing that assessment. Thank you for being involved in rural healthcare. We recognize that it's very tough to get providers out there, and we thank you guys for what you guys do.
Okay, does anyone else have any questions for Dr. Mishra? Well, thanks for joining us all today.
Great job. Thank you.
Yeah. I will send out a PDF version of the PowerPoint to Amanda and Carolyn. And thanks again. Yeah, we really appreciate it. So thanks for taking the time.
Of course.
Okay, have a good day. Bye-bye.
All right. See you guys.
Thank you so much. Thank you so much, Alex, for all your help.
Thanks, Dr. Mishra.
Of course.